Good evening, everyone. So today we are going to discuss about one very important epidemic that happened in India, that is obesity. And there is a synergism between two epidemic. One is obesity and another is diabetes. So we will discuss about this obesity management in diabetics. So before that, going in details, I just want to share one real life case that I had faced 2 days back. So a 70-year-old type 2 diabetic, hypertensive, chronic kidney disease patient who is also suffering from interstitial lung disease and hyperuricemia uh, was visiting me for last 2.5 years. So this is, I just give one snapshot of his August 2020 prescription and then August 2021 prescription. Just 2 days back, I had prescribed this medicine. So in August 2020, we can see he was on glargine 16 unit, anti-diabetes medications like linagliptin, repaglinide, and antihypertensive drugs like amlodipine full dose 10 milligram, nebivolol 5 milligram, telmisartan full dose 80 milligram, apresol dihydroxyzine, that means 25 milligram thrice daily, Titanix 2.5, atorvastatin 20 milligram, clopidogrel 75 milligram, sildosin 8, and febuxostat 40 milligram, along with different inhalational agents and antifibrotic therapy as prescribed by his pulmonologist. The thing is that with this lots of antihypertensive drug, this particular gentleman, his BP was not that much optimally controlled. And with this type of, if you increase the dose of diuretic, the patient suffered from hyponatremia, lots of complications. So now you can see the prescription which was done 2 days back. Only nebivolol 5 milligram and S-amlodipine 2.5 milligram was there with atorvastatin, clopidogrel fixed dose combination, sildosin was there, and febuxostat. Apart from that, the inhalational agents and other antifibrotic therapy was continued. But the thing is that these medications, these antihypertensive drugs, we can see the difference. This was he is taking for last 1.5 month, and he was not on any anti-diabetes medication. So this is very important to note. And another important aspect, already we had discussed his uncontrolled blood pressure. But now you can see with this 1.5 month therapy with this nebivolol and amlodipine, S-amlodipine combination, only 2.5 milligram S-amlodipine and nebivolol 5 milligram, his BP is optimally controlled, 130/80. Previously, when he had visited me repeatedly, his BP was, systolic BP was 150 to 160 millimeter of mercury. So what is the magic? Why this happened? So now again, if we just compare the lab reports, the creatinine value was 1.9 milligram, urine ACR was at the range of macroalbuminuria, it was 396, and HbA1c was 7.6 in 2020. But in recent report, we can see the creatinine levels goes down, fasting 94, pp 147. So why this happened? So the thing is that his body weight in August 2020 was 89 kg, whereas in the August 2021, 2 days back, when I had checked his body weight, it is only 61.5 kg. So how this happened? Yes, this weight loss is not physiological. This weight loss has a severe, we can say, contributions due to this infection. He had suffered from severe COVID-19 pneumonia and admitted in 7/5/2021. He was in a little bit critical stage. Apart from that, after being discharged from COVID, he had again a readmission due to Clostridium difficile infection. So this whole lots of infection gamut, the trigger in the interleukin 6 level and other inflammatory markers, specifically the tumor necrosis factor alpha, which is responsible for this weight loss. We don't recommend this type of weight loss in real world setting. We don't want this type of weight loss in our patient. But what is important with this type of scenario, if we can reduce body weight reduction has direct contribution in reducing blood pressure, improving the cardiovascular health, and mostly controlling the diabetes. So here in this particular patient, we had found that the patient was on insulin, repaglinide, linagliptin, but this type of weight loss is not on any anti-diabetes agent. So there are studies which suggest if we just reduce 7% of body weight, that causes marked improvement in terms of insulin sensitivity. So this is why we need to reduce obesity. And this was the first randomized control trial which was published in NEJM, and we can found that how with lifestyle modification we can reduce the incidence of diabetes. So just a 7% of their body weight reduction, that is associated with 58% reduction in the incidence of type 2 diabetes. And this is really phenomenal. And if we just go to the definition of obesity, which is also known as state of excess adipose tissue mass. So this is the classification as per WHO. But if we go by the definition of Indian context, then that is normal BMI means between 18 to 22.9. Anything more than 23 or more than that, up to 24.9 is overweight. Obesity is defined as if the BMI is more than 25 kg per meter square, which is important to note that in a world where food supplies are intermittent, the ability to store energy in excess of what is required for immediate use is generally essential for survival. Fat cells that resides within widely distributed adipose tissue depots are adapted to store excess energy efficiently as triglyceride. And what they do? They release the stored energy as free fatty acids to use at different other sites. And this physiologic system orchestrated through different endocrine and neural pathways, and they permit human to survive the starvation for as long as several months also. And we know that in our system, in Indian population, there is a starvation of food, and we really have to live with this mechanism. But what happened now? In the presence of nutritional abundance and a sedentary lifestyle, there is also some genetic influence also that synergize this mechanism. This system increase the adipose energy stores and produce different obesity related adverse health consequence. And that is one of the major reason for that our obesity threshold is little bit lower than our Caucasian friends. waist circumference is again a very important issue, because we don't know about the visceral fat estimation. So waist circumference can give us a very good input regarding the visceral fat accumulation. And for that, what is important cutoff for men, if it is 78 centimeter or more, or for women if it is 72 centimeter or more, then we need to be very cautious from that level. So any person with waist circumference above these levels should avoid gaining body weight and maintain the physical activity to avoid acquiring any of the cardiovascular risk factor. So from this threshold, we need to be very alert. And which threshold is dangerous? For men, if it is 90 centimeter or more, and for women, it is 80 centimeter or more. So above this waist circumference level, the person should seek medical help so that the obesity related risk factors could be investigated and managed. They need urgent attention. And this is why it is now very important to check your waist circumference. And this is one area where we doctors are very much negligent regarding our own health. It is important to check your belt size, check your waist circumference, because ECG, echo, we don't need that too. Before doing ECG echo, we can predict if the waist circumference is high. We need to be very alert to prevent different types of cardiovascular ill effects. So waist circumference is really important tool to understand whether I am going to develop any cardiovascular morbidity. Apart from that, there is another important area, that is the waist to hip ratio. For women, if it is more than 0.9, and for men, if it is more than 1, then it is called as abnormal. If we just remember the picture of an apple and a pear, it is always better to have the shape of a pear rather than an apple. So apple-shaped obesity is carrying very poor, or we can say that detrimental cardiovascular health. So we don't want apple. So our upper body obesity is more, or we can say worse, than our lower body obesity. So that is why it is important to check the waist hip ratio also. So now this is very important, the energy intake and expenditure. So it is always important to balance between what you are earning and what you are wasting. So you need to know about your balance. So here always better to earn less and waste more money. So if we have to understand the energy expenditure, there are 4 broad headings. And what are those 4 broad headings? Number 1, the resting or basal metabolic rate. Number 2, the energy cost of metabolizing and storing the food. Number 3 is the thermic effect of exercise. And number 4, the adaptive thermogenesis. This is a very important concept we will discuss. This adaptive thermogenesis varies in response to long-term caloric intake, and this generally rise with increase intake. So this is the concept why we should not prescribe or advise our patient to take less calorie diet drastically. We should follow a gradual reduction in the intake. Apart from that, what is important to note is the appetite. Appetite is influenced by many factors that are integrated by the brain. And in brain, what is the most important thing? That is the hypothalamus. So hypothalamus is regulating this appetite. The signals that impinge on the hypothalamic center include different neural afferents, hormones, and metabolites also. Vagal inputs are particularly important. They bring the information from the viscera, like gut. If the gut distension is there, so they bring some information to the via the vagal input to the hypothalamus. And there are some hormonal signals that include leptin, insulin, cortisols, and different gut peptides, including incretin. Among the later, this hormone, the ghrelin is one of the most important one, which is made in the stomach and stimulates feeding. There are some other peptides like peptide YY, cholecystokinin, which is made in the small intestine and signal to the brain through direct action on the hypothalamus, or sometimes via the vagus nerves also. There are metabolites like glucose that also influence appetite, as we see in case of hypoglycemia, which induce hunger. However, the glucose is not normally the major regulator of appetite. But as we are talking about the energy expenditure, and here the number one is that resting or basal metabolic rate. This basal metabolic rate accounts for 70% of daily energy expenditure, whereas the active physical activity that contributes only the 5 to 10%, this thermic effect of exercise. So the significant component of this daily energy consumption is fixed in terms of resting or basal metabolic rate, which is 70%. And this adaptive thermogenesis is not a thing which can be acutely changed. And for that, we need to understand one very important concept, that is adipostat. So this adipostat set point concept is very important while managing our obesity patient. So in this diagram, we can see a situation in which the signal that is normally considered to be leptin, this signal indicates a level of body energy reserves lower than those required by the adipostat set point, and it regulates the food intake positively and thermogenesis negatively to restore the desired level. And there is some continued interest in this concept of body weight set point or adipostat. And this idea is supported by physiologic mechanisms that centered around this particular sensing system in adipose tissue, and that reflects the fat stores and a receptor, or we can also talk it as a adipostat, just like a thermostat like concept. And this adipostat can be two types: central adipostat, which is present in the hypothalamus, and also the peripheral adipostat, which is present in the peripheral adipose tissues. So when fat stores are depleted, the adipostat signal is low, and that hypothalamus responds by stimulating the hunger and decreasing the energy expenditure to conserve energy. Conversely, When fat stores are abandoned, the signal is increased and the hypothalamus responds by decreasing hunger and increasing the energy expenditure. But what happened in pathology? This adipostat also becomes deranged. We all know the consequence when the thermostat is not properly working. So same thing happened here, and that we need to consider while managing our obese patient also. So no drastic decision should be made while seeing obese patient. We need to go step by step. So management of obesity starts from history taking itself, because whatever conversation during history taking, that will directly help us managing those patients. Thorough clinical examination, lab investigations to rule out different obesity associated diseases, motivational program, active involvement of the psychologist is very important. Diet and exercise, if we have a team of dietitian and exercise specialist, so that will be very good. There are some limited role. I must say it is a limited role of pharmacotherapy in obesity. Though there are some drugs available, we'll discuss in brief later. And there are some definite role of bariatric surgery. So as already we had given importance on the history taking, the history should be obesity focused. And with this history taking, our management will be initiated. Because whatever we are talking with the patient, that message should have some effect on those patients' behavioral changes. The patient should have behavioral changes. So we need to ask what factors contribute to the patient's obesity. How is the obesity affecting the patient's health? What is the patient's level of risk from obesity? What are the patient's goals and expectations? Is the patient motivated to begin a weight management program? So the motivation level, and what kind of help does the patient need? So this type of question actually help us to get the active involvement from the patient. And this is a very important lifestyle history taking questionnaires from Queen's. So Queen's lifestyle history is very important, which contains few important aspects of lifestyle disease. Importance of nutritional history, physical activity level, whether he or she is taking tobacco or alcohol use, what are the sleep habits, stretch management, and how their relationships with family. These all are important in the lifestyle history. And apart from that, which is important is the sleep habits. So the pattern of the sleep is important. The circadian rhythm, whether it is going to disrupted or not, because the destruction of circadian rhythm is also associated with different types of metabolic diseases. So we need to take detailed history on that. And for that, we have a very good metrics like cardiovascular health goals metrics. So there are three categories: poor, intermediate, and ideal. So in each sectors like current smoking, BMI, physical activity level, health diet score components, total cholesterol level, blood pressure, and fasting plasma glucose value. Here we can categorize our patient with their respective values, and we can tell our patient, you are now in this group, we need to make you in the ideal group, and that should be a gradual process. Here the cutoff are Caucasian cutoff, we need to consider the Indian cutoff here while seeing our own patients. And then I just want to share this, though it is not published till, but we are going to publish it very soon, that we had conducted one study, cross-sectional study among our medical representative friends. And we had found, unfortunately, that 80% of those medical representative friends are belonging to this poor category as per their cardiovascular health goals or metrics. Despite most of them are physically active, they are belonging to this poor group. So this is one thing we need to assess, and we need to consider this type of screening among us also, that because doctors are most vulnerable population. While seeing our obese patient, it is important to consider the different comorbidities. As we are seeing obese diabetics, so we need to check whether the patient has any hypertension, cor pulmonale, coronary artery disease, obstructive sleep apnea, any type of GERD. So all these aspects we need to see holistically. And as a clinical pharmacologist, one of the most important area on there is the medication reconciliation, and for that the iatrogenic comorbidity is very important, because iatrogenic obesity is also common. We need to take proper medication history. There are lots of drugs which is commonly used that increase body weight. So we need to deprescribe those drugs if required. So this is very important, and after deprescribing, we can choose alternative drug which has some weight neutral effect. Just like I am giving one example, one of my patient who was suffering from migraine was on valproate. So his body weight was at around 90 kg. So we just deprescribed valproate and started a drug and called as topiramate, and we found that the headache was well controlled, and from 90 kg the weight becomes 80 kg. Yes, of course, we had also instituted the lifestyle modifications advices along with this deprescribing. But why it is important, we need to give emphasis on this iatrogenic perspective also. Now coming to this closed loop cycle of diabetes and obesity. So weight gain in a person with family history of type 2 diabetes, that causes increased need of glucose, and for that beta cell secretes more insulin. But what happened in the peripheral level, as there is obesity, patient has insulin resistance. So in the liver level of liver, muscles and adipose tissue, there is insulin resistance. So that cause more insulin to be secreted, and that is responsible for beta cell exhaustion, and ultimately the patient will end up with type 2 diabetes, or this insulin resistance is contributing to hypertension. So we need to emphasize each aspect very well. And what is important, we need to assess the patient's readiness to change. So readiness can be viewed as the balance of two opposing forces. So there is two opposing forces. Number one, the motivation or the patient's desire to change, and number two is the resistance or the patient's resistance to change. So we need to make our patients motivated, and for that one thing is very important, and that starts from the history taking, that how we approach our patient. So we should, this is an example, that our language should be very much rational. We should utter person with obesity rather than just telling obese person, you are an obese person. So this type of thing is very important. We should not attack the mindset of our patient. Mentally, there should not be any attack. So use patient-centered, non-judgmental language that fosters collaboration between patients and providers. And another important example how we can modify ourselves. There should be a specific accommodations for patients for taking weight. That should be maintain the privacy. My patient should not expose to all the other people who are waiting there with his body weight. There should not be any shame game. So this is most important. So as already we had mentioned, our goal, first of all, we need to reach a little achievement. So diet, physical activity, and behavioral therapy that should be designed to achieve and maintain at least 5% weight loss. If there is greater weight loss, that is associated with more benefits. And for that, initially, we should have more behavioral counseling with the help of our psychologist friend. So more than 16 sessions in 6 months. That is most important. Recommended by ADA 2021 guideline you can find. There should be a focus on dietary changes, physical activity, and behavioral strategies targeting 500 to 750 kilocalorie per day energy deficit. By decreasing the diet and increasing the energy expenditure, we need to have a at least 500 kilocalorie per day energy deficit. And everything should be individualized, depends on individual's preference, motivation, and life circumstances, and of course the medical status. A patient with osteoarthritis, bilateral grade 3 or severe osteoarthritis, we cannot tell just you have to walk for 1 hour. So this should be individualized or personalized. Behavioral change that create an energy deficit regardless of the macronutrient components cause weight loss. So this is important. We need to reduce that calorie. And already we had mentioned that dietary recommendations should be based on patient's preference and nutritional needs. So we can see from the 2013 obesity guideline that only 3% weight loss decrease the risk of developing diabetes. If it is 5%, that means it improved blood glucose level, blood pressure level value, HDL and triglyceride value. And if it is more and more, the improvements in the above parameters will be greater. So now coming to the adherence, which is very important for any long-term therapy. And obesity is nothing but it should be a continued therapy, a long-term therapy. So what is adherence? The extent to which a person's behavior of taking medication, following a diet, and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. And I think the management of obesity is very much dependent on this adherence. So there should be an active involvement from the patient side. Here I just want to mention that adherence is not equal to compliance. In compliance, there is no active involvement from the patient. But adherence, there should be active involvement. It is a patient's agreement to the recommendations. Patient agree to what I am saying, I am advising him. So here the patients are active partners with healthcare professionals in their own care. So healthcare professionals will act as a coach, but the patient have to act as a footballers, and they have to score goal by their own. This is most important. And for that, we should focus on multidisciplinary weight management, which consists involvement of dietitian, physician, exercise physiologist, and psychologist for behavioral therapy. And if everything fails, then we need to go to the metabolic surgeon or bariatric surgeon for surgery. Now coming to the one of the major tool to reduce body weight, that is the diet therapy. So we need to initiate treatment with a calorie deficit of 500 to 1000 kilocalorie per day compared with the patient's habitual diet. So this calorie deficit is very important. And among that total calorie, around 45% should be from the carbohydrate. In the diabetes patient, it is better to make that carbohydrate percentage between 40 to 45%, not up to 60%. It is important to restrict carbohydrate up to 45%. There is, we can prescribe 30% fat, and among that fat, 14% should be MUFA, monounsaturated fatty acid. At around 12%, it can be PUFA, polyunsaturated fatty acids. And saturated fatty acid should be less than 7%. And trans fat, the creamy thing which is present on the cake or on the patties or in the samosa, that trans fat should be less than 1% per day. Protein is very important for our diabetes patient, and the requirement is 1.5 gram per day. 1 to 1.5 gram per day protein we require. 1.5 gram per kg per day. Fibers are important. Generally, for 1000 kilocalorie diet, we need at around 18 grams of fiber. So more or less, a diabetes patient should get at around 25 to 30 grams of fiber per day. Fish is very important because most of the fish, specifically which are high in omega-3 fatty acids, we require that at least 2 servings. We need to reduce the sodium intake, that should be less than 2300 milligram per day. Milk is important, specifically the low fat or fat free dairy products are good. And by the way, this diet therapy, how it is important for our cardiovascular health, this cartoon we can see. So more glucose. So if there is more carbohydrate we are taking, so there will be more glucose, and that glucose cause stimulation in the pancreas. So the pancreas beta cell will secrete insulin, and that insulin will take care of that glucose things. And if the glucose is absorbed, so there is something reactive hypoglycemia, and that cause increase in hunger, and we will take again samosas, potato chips, different carbohydrates. So the cycle will go on and on. But what happened? There will be more insulin in our body. So that will cause more lipogenesis, and more lipogenesis means our abdominal circumference will be increased. So there will be high triglyceride value, low HDL, and also due to this insulin resistance, there will be increase in blood pressure. So ultimately we'll end up with cardiometabolic syndrome. So we need to take care. We need to stop this vicious cycle by limiting our carbohydrate intake. And as we are talking previously about our money balance, here the calorie balance. So if there is less calorie that is present in our pocket, that means we are more healthy. So what happened if there is positive calorie balance? So if there is positive calorie balance in pre-existing insulin resistant patient, so that what happened, there will be more liver fat, and that cause increase in VLDL level, triglyceride level that reach the islet cells. So more islet triglyceride levels. So ultimately what happened? There will be decreased insulin response to ingested glucose level. So that cause postprandial hyperglycemia. And as there is higher fat in liver, so that also cause resistance to insulin suppression of glucose production. That cause increase in the basal insulin secretion. So that is the liver cycle. So liver cycle causes fasting hyperglycemia and pancreatic cycle causes postprandial hyperglycemia. So ultimately what we need less money in our pocket. We need to cut that positive calorie balance. If we can make it a negative calorie balance, then these two vicious cycle will be stopped. And for that, there are definite role of meal replacement, low calorie diet. And this is a systematic review on different meal replacement therapy. And we can see clear-cut benefits in this forest plot in favor of meal replacement. And another systematic review and meta-analysis of a few randomized controlled trials. There we had found that the effect of meal replacement based low calorie diet on weight loss was superior to the effect of food based LED, and who are receiving more than 60% of total daily energy intake from meal replacement had the greatest effect. We can see this forest plot. Here we can see the population who are taking more than 60% of the calorie proportion of the calorie that intake from the meal replacement. So they have the much better benefit. But all throughout the group, we can see in this forest plot, the benefits are in favor of treatment. That means in favor of meal replacement, and more benefit if it is the more than 60% from the meal replacement. But regarding the meal replacement, there are few important things need to be considered. As already we had mentioned, the importance of personalized advice. We just cannot say a patient you have to take meal replacement of 60% of your calorie, because that is not increase the adherence, that will decrease the adherence, and that ultimately leads to failure of anti-obesity management. We need to understand the patient need, whether the patient will cope up with this meal replacement, that we need to understand. Then we can prescribe. Meal replacement has a definite advantage, but the problem is continuation. For long term, the patient will not continue meal replacement because tongue is important, taste is important. So we need to be individualized. Precision diet is very important. Now coming to another important pillar of obesity management, and that is exercise. So in general, a total of 60 minutes of physical activity is recommended every day, and this should include at least 30 minutes of moderate intensity aerobic activity. That can be brisk walking, jogging, hiking, gardening, bicycling, etc. 15 minutes of work related activity. That can be climbing stairs, walking during breaks, etc. 15 minutes of muscle strengthening exercise using light weights. For elderly population, that can be prescribed every alternate day to avoid muscle fatigue. Aerobic activity should be performed in bouts of at least 10 minutes in duration. So total duration of physical activity could also be accumulated in small 10 to 15 minutes period. At least we can afford 15 minutes at a time. and that can be divided into 2 to 3 times a day. So 15 minutes periods of physical activity 2 to 3 times a day. Just like many drugs we prescribe, you have to take this drug, paracetamol 650 milligram, you have to take 3 times daily. Just like that, we can prescribe exercise. You have to do brisk walking for 15 minutes 3 times daily. But this prescription is very important. And again, here also the importance of individualization, the personalized exercise plan that based on each patient's age, gender, health status, and exercise capacity. Weight reduction and maintenance of weight loss cannot be achieved alone through the typical recommendation of 10,000 steps per day or 150 minutes per week of aerobic exercise. We cannot just make blanket prescription of 150 minutes per week aerobic exercise, or from tomorrow we will start 10,000 steps per day. It should be a gradually increasing one, because otherwise again we will fail in terms of adherence. Again, the importance of aerobic resistance exercise, flexibility exercise, extremely important. Different types of stretching exercise, because that increase the muscle mass, reduce the risk of injury, and improve cardiovascular health. Sometimes we can test a 6-minute walk test we can do, and we can understand the exercise capacity for a particular patient, and we can have a personalized exercise plan for them. So these are very important tools. Apart from that, there is definite role of yoga, pranayama, and there are lots of studies which suggest they work fantastically. In obese patient means the sympathetic nervous system is hyperactivated. And already we know the diabetes is associated with autonomic neuropathy. So both of these synergism will be detrimental for the health of autonomic nervous system. And for that we need yoga or pranayama, because if we can have that yoga and pranayama, that increase the vagal tone, parasympathetic nervous system tone. And if we increase the parasympathetic nervous system tone, that can give us a balance between sympathetic nervous system and parasympathetic nervous system. Samatya, samattang yoga uchvate. We know Lord Krishna told long year back about what is samatya. So by this way we can have a personalized plan for exercise. When to start pharmacotherapy? Again, this is the recommendation for our Caucasian friends, but for Asian Indians, these are the recommendations. So pharmacotherapy should be initiated for BMI above 27 kg per meter square without comorbidity. But if the patient is obese, that means BMI 25 or more with comorbidity like obesity with diabetes, and BMI is 25 kg per meter square. So we need to consider a start of pharmacotherapy. Waist circumference measurement, if it is 10 centimeter more than the upper limit of gender specific normal value of adult Asian, like if it is 100 centimeter in male or 90 centimeter in female, then we should consider to start pharmacotherapy. When to consider bariatric surgery? If the BMI is more than 32.5 kg per meter square with comorbidity like diabetes or hypertension along with obesity, and if it is more than 37.5 kg per meter square, so independent of presence of comorbidity, we can consider the patients to have bariatric surgery, and we need to refer this type of patient to the bariatric surgeon. Now coming to the efficacy of different anti-obesity drugs. So this is the percentage estimated weight loss compared to the placebo, drug minus placebo arm, but most of these drugs are not available in India. Orlistat is only available. But here I will share my thought on these anti-obesity drugs in my future slide. So these in general, what are the different medication that is approved by FDA for the treatment of obesity? So there is a sympathomimetic amine which is act as an anorectic agent, that is phentermine, but it definitely cause dry mouth, insomnia, dizziness, irritability, high blood pressure, and sympathetic nervous system stimulation. So generally, we should not use this group of drugs in our obese patients who are suffering from diabetes, and generally contraindicated for use in combination with monoamine oxidase inhibitors. We can use lipase inhibitor, and this is DCGI approved Orlistat, and it has a role definite, but the problem is with its GI adverse effects. There are some abdominal pain, flatulence, and fecal urgency. We need to educate our patient, because informed prescribing is very important while prescribing Orlistat, because otherwise patient will be very angry with you if you not educate patient on the side effects of Orlistat. There will be potential malabsorption of different fat soluble vitamins, which is common, and some medication, specifically if a patient is on thyroid medications, we need to be very careful. I had seen more than 50 patients who required L-thyroxine replacement, increased in L-thyroxine replacement, who are on Orlistat, who were initiated with Orlistat, need to increase the dose of L-thyroxine supplementation replacement. So there are some sympathomimetic, amine, anorectic, and anti-epileptic combination, phentermine, topiramate, that is also generally not should not be used with MAO inhibitors. It has some it is totally contraindicated in pregnancy, and cognitive, it can cause cognitive impairment, acute angle closure glaucoma, and it is not available now. And due to phentermine, as phentermine cause increase in blood pressure, we need to be very much careful. Naltrexone bupropion combination, again a opioid antagonist and antidepressant combination we can use, but there is a black box warning, risk of suicidal behavior or ideation, specifically in those patients who are 24-year-old or lesser than that and having depression. But bupropion is a good drug. In India, bupropion is available. We use in different other areas, and we get some benefits in terms of weight reduction also in isolated bupropion therapy, even in topiramate therapy. But the patient should have some primary other indication for what the patient is taking that particular drug. That already we had discussed. If a patient is suffering from migraine, we can prescribe topiramate if he is obese, or if a patient want to stop smoking, there we can use bupropion. Patient has some depression along with erectile dysfunction, and patient needs weight reduction, we can use bupropion there also. Liraglutide 3 mg is not available in India. Again, this is a promising molecule, and yes, like GLP-1 analog, it has gastrointestinal side effects, pancreatitis, and obviously, like all GLP-1 RA, there is a black box warning of risk of thyroid cell tumors. We need to take history, that whether the patient has any family history of medullary thyroid carcinoma. So we should not use liraglutide or any GLP-1 RA. But the important thing is that the increased expression of C cell generally present in the rat, but not in the human. Human thyroid cells not contains that much of C cells expression. And that is why all the trials, all the large CBOTs on GLP-1 RA, they does not produce any signal on these thyroid C cell tumors. So in India, only the orlistat is approved for obesity management. There are some phytopharmaceuticals. There is one few pharmaceuticals which are claimed to be anti-obesity drug, but we need more robust data on those. Lorcaserin was introduced in Indian market at around 2018, but it was withdrawn due to its carcinogenic effect. It is not used now. Now I am coming here why we should talk less about the anti-obesity drug, and we need to give emphasis on lifestyle modification and advices, because the efficacy benchmarks, if we just see by FDA, so a product can be considered effective for weight management if after 1 year of treatment either of the following occurs. So in the 1 year of treatment, what happens? The difference in mean weight loss between the active product and the placebo treated group is at least 5%. So there should be a 5% difference, and that should be a statistically significant. And number two, if the proportion of the subjects who lose greater than or equal to 5% of the baseline body weight in the active product is at least 35%. So 35% of the active group has a 5% body weight loss. And that is double the proportion of the placebo treated group. So if a drug A causing 5% body loss in 35% patient who are taking this drug, and the placebo group, if it is only 17% who has a 5% body weight loss, then we can approve one drug as an anti-obesity drug. So here we want to note that 35% of that active group has 5% body weight loss. But what happened to that 65% population? They does not have at least 5% of body weight loss. So this is very important to consider while prescribing a drug. Bariatric surgery has a definite role, and there are newer techniques like sleeve gastrectomy or endoscopic sleeve gastroplasty. They are becoming popular nowadays. But as we are talking about our diabetes patient, the history of concomitant medication is very important. We need to give emphasis on those drugs which increase the body weight, like pioglitazone, sulfonylurea, glinides, or different types of insulin. And if possible, we may stop or reduce the dose or switch to other agents. There are some drugs which are weight neutral. We should not intervene in terms of obesity management, like metformin, DPP4 inhibitors, alpha glucosidase inhibitors. They are weight neutral. And there are some drugs which promote weight, like GLP-1 analogs. They promote weight, SGLT2 inhibitors. So in patients, compelling the need to minimize weight gain or promote weight loss, here we can see, we can choose GLP-1 RA or SGLT2 inhibitors on top of metformin. And these agents can increase the weight loss. So coming to the last slide, and what is important, we need to believe firm. And that firm means our objectives, specifically the behavioral objectives, should be few in number. Keep the number of changes to a minimum. So one goal at a time. Just you will tell your patient for next 1 week, you have to increase the physical activity and you have to modify a little bit on diet. Then next week, you will give some dietary implication. So that should be a step approach. You should go gradually. Individualization, precision medicine is very important. That should be tailored to the patient and their lifestyle, their income, their habits, likes and dislikes. Just we should not blanketly prescribe meal replacement therapy. We need to understand the patient need. We should be realistic. We should be practical. We should help the patient to choose the practical, attainable goal. Just like example, just switching from a regular soda to diet soda, small intervention. Just not like that you should stop all Coke. From tomorrow you will not get any Pepsi, any Coca-Cola. Instead of that, if you tell your patient, from tomorrow you stop Coca-Cola to start Diet Coke, but you reduce the intake of that Diet Coke. You reduce the calorie slowly. So like this, we need to be realistic. And oftentimes, patient believes they have to achieve a normal body weight within a specific time frame. But improvements can be achieved with initial weight loss of at least 0.5 kg per week. So target that 0.5 kg per week. We should not just tell our patient from tomorrow you have to walk 10,000 steps. Our objective should be measurable. So set specific metrics such as walking 3,000 steps a day by using some pedometers for 2 weeks, then 5,000 steps a day for next week, then 7,000 steps for another 1 week or 2 weeks or 3 weeks. Then we need to reach that 10,000 steps goal. So we need to keep the behavioral objective firm. And most importantly, we need to believe this accountability ladder. So initially the patient will deny in a denial mode. They will stay in this position. But it is our duty. It is the duty of our team, which consists a physician, a dietitian, exercise physiologist, psychologist. This is a multidisciplinary team. They will make our patient to go up to this position. So initially it is, I don't know. They will give some excuse. Then they will tell, wait and hope. And sometimes they will blame others for this weight gain. But ultimately your success will start if they start acknowledging the reality. Then own it. Then they will find solutions and ultimately make it happen. So this is the effort you need to give. With that, I thank you all for having, for hearing me for this at least 1 hour. So I really thankful to all of you. And we need to consider this obesity epidemic because we Indians are different. And this is the famous Yajnik from whom we start learning that we are really different from our Caucasian friends. And for that, we need to give emphasis on managing our obese patient. With that, I thank you all. Thank you for hearing. And I must acknowledge that these presentations are mostly based on from the teachings of my teachers, Professor Santanu Tripathi sir, few lectures of I am a great fan of this great teacher, that is Professor Shashank R Joshi sir. And of course, I had a chance to get to learn from this great diabetologist, that is Professor Anoop Mishra sir. And also I want to thank Professor Nilanjan Sengupta sir, who had taken up many classes in different podium regarding these principles of obesity and specifically the diabetes management. So with that, thank you all. Good night.